Age Tech Innovators.
Hello, and welcome to Age Tech Innovators, the podcast where we explore how technology is transforming the way we care for our vulnerable population. I'm Monty, your host, and each week we chat with inspiring leaders who are making a real difference in the lives of vulnerable adults, sharing innovations and ideas that help support and uplift those who need it most. Join us as we work together to build a brighter, more caring future for everyone. Now, let's dive in. So I have the absolute pleasure of chatting to David today. David, run me through who you are and what you do in 60 seconds.
Yeah, absolutely. First of all, I mean, it's an honor to be considered, somebody who's, making a change in this space. But, again, thanks for having me on. My name's David Moore. I'm the Chief Operating Officer for Prevent Scripts. I'm really excited to share our work and the perspective for the future of age tech and a lot of stuff that we're doing and how we support the age tech space. From my background, it's a bit unconventional as I started out in nursing and have worked my way through healthcare and the management of technology. But this journey has given me a deep understanding of how we can innovate in prevention and support elder care.
Amazing. Really excited to hear a little bit more. Can you run me through how did you mention you came from a background of nursing? How did you go from nursing to actually be involved in a platform that helps manage patient monitoring? Can you run us through a little bit more about what Prevent Scripts is actually actively doing?
Yeah, so it's kind of an interesting story in the sense that I actually have a tech background as well. I'm very passionate about technology, always tinkered, as growing up, always playing around with technology and computers and, building my own computers and stuff and networks and all that. Very just driven by technology and what it can do through our daily lives. But then while I was kind of going through school, I realized, my family has a family business, a cleaning business. And so I was looking at what my pay scale is going to be in technology versus just going to work with the family business. And I was like, okay, I'm not going to make any more over here, but if I just went into the family business. So I decided to go into the family business. I did that for about 8 years. And then I realized, the family business is great, but I'm self-employed. I don't have benefits. I don't have paid vacations, and I had insurance coverage. I decided it was time to go back to school, but I wanted to go into healthcare. My father was a paramedic for 42, 46 years, somewhere in there. Uh, he was actually on the television show Rescue 911. They came in and they did an episode of one of the cases that he worked. And as a young boy, getting to watch them film that and see what my dad did on a regular basis, it was like a superhero kind of moment for, me and my dad. And that kind of instilled that passion of helping others in me. And so I wanted to go into healthcare. I knew that. And nursing seemed like the most reasonable next step. I didn't want to go do, the full doctor thing because didn't want to be in school that long and didn't want to have that much debt. And I knew I could get the nursing done in about 2 years. So I went back to school, got my nursing degree, started out working in the OR. I thought that was the one place when I was going through nursing school that I would not be able to handle working in because it looked like the most boring job on the planet. I ended up loving it, but it also gave me the opportunity to work with doctors on a level that I don't think I would have gotten anywhere else. Because they put their white coat on when they're out in public, when they're on the floor, and they're in their office. And they have a persona that they're trying to kind of push out there. And back in the OR, that white coat comes off. So I got to really develop working relationships with them on a different level. That has helped me throughout my career. But from there, another local hospital was building an OR suite, and I went and worked for them for a while and launched it, built out all the documentation for them. Talking with the CEO after we opened it, he asked me to take a look at the rest of the hospital. And that's the point in my career where I kind of got to shift more into the informatics and kind of bringing the technology into the daily workflows and operations. And so I did that for a while. And then I got to looking into a company called VillageMD. Their value-based care organization is also opening up de novo and combo clinics with Walgreens. And I got to talking with them. They offered me a job as manager of population health operations. And so I went into that role thinking I understood a little bit about value-based care. And then I got the crash course in a lot of valuable insights that I learned during my time there. But I worked my way up to market president for the state of Kentucky with them. And there's a lot of awesome things happening with value-based care, but it's really not getting to the root of what is the problem in healthcare, which is generally just the unhealthy lives that we live for the most part. And so while I was working with Village, I came across a company called Prevent Scripts, and they were trying to get into this early prevention, detection, and prevention game. And it sounded pretty amazing, but they didn't have a revenue model behind it. But at the time, they were just looking to try to collect data on, their process. That is it working? Is it actually, generating outcomes? And so we partnered with them. They were able to collect some data. Fast forward 5 years, they put a revenue model behind it, which is kind of what we're here to talk about today, somewhat in the fact that we're leveraging remote patient monitoring, RPM, and as a source of generating that revenue, but still allowing the patients and supporting them on a level that is meaningful, that generates those outcomes.
Can you just run through a little bit more about this transition from not having a clarified revenue model to actually having a clarified revenue model and using RPM as a way to generate additional revenue?
I'm really excited that you asked that because, and that's one of the things I want to encourage people, that watch or listen to this is try to think outside the box in the use of, the structure that you have. What we're doing is something that, to my knowledge, nobody else is really doing, and how we're leveraging RPM for preventative services rather than managing chronic conditions per se. And we've got to be a little tricky on how we handle that because usually RPM is considered or thought to be meant for managing chronic conditions, but it can also be leveraged for the prevention of chronic conditions. So someone who is obese, for example, or morbidly obese and has metabolic syndrome, they are at high risk of developing diabetes, cardiovascular disease, a number of chronic conditions. And as a preventive measure of preventing diabetes, you can leverage RPM to prevent it as your plan of care. And so we thought outside the box and how we were putting together this model. We have about 12 codes that we kind of like to consider somewhat proprietary because no one else is really leveraging them in the ways that we are. But RPM's a fairly basic one that's out there. That's how we went from having no revenue model to how do we figure out how to get a payment system to actually reimburse the providers for the work that we're doing with them. And so that's how we did it.
That's super interesting. So because when someone has a chronic, I'm already hyped. 8 minutes in, I'm already hyped. When someone has a chronic condition, they are identified within the healthcare system as, yes, we can do remote patient monitoring. But you're saying something along the lines of, well, before they develop a condition, they are high risk because of potentially being obese. How are you identifying these people and then actually starting to monitor them when they don't have an illness at this point?
Right. So we have a pre-program assessment. So the way it essentially works is we partner with a doctor, usually primary care provider, and they have patients scheduled to come into their practice to be seen, obviously. So the day of their visit or, the week before, whatever they choose. So we work with the providers to customize how that really works. But the patient appointment reminder, we include a link now that says, please complete this assessment prior to your visit with your doctor on whatever date. So the patient will click on that link, takes them to a landing page. They fill out some information, demographic information, very basic. And then they go through 4 validated assessments, essentially, that gives us, and we take that information and we build a patient profile, basically. So we are able to determine the risk factors for developing diabetes. We start getting into some understanding of the risk of developing cardiovascular disease. One of the things that we do with this is we use Prochaska's declimatic stages of change to identify their mindset and readiness to actually make a change in their health. And so we leverage that so that we're being smarter about resources. So a patient who is not in an action stage or pre-contemplative even, it's not a good patient for us to put a lot of resources into. So we put them in kind of a backdoor kind of channel of we're going to continue to support you. We're going to give you some emails once a month or every 6 months educating you, and so that we're hopefully moving you into an appropriate stage of change through education.
Just to double check, what was the name of that framework? This is crazy, but what was the name of that framework that you're using to try and understand people's readiness of adopting new change devices or
Yes.
technologies?
So it's Prochastis de Clemente's stages of change. We've got some behavioral health experts that we've worked with in developing this. But, he was one of the first to develop, I guess, the survey or assessment, and you can apply it in different ways. But it's really, we're all of us in any given time are always in a state of change in any kind of decision making, whether it's your health or whether you want to go to the grocery store. You go through these stages of change. And so we're able to leverage that to just be smarter about how we are implementing resources with supporting these individuals.
That's the first time I've heard this being used in the telehealth, telecare space, which is identifying with the service user their likelihood of adopting a new technology or a new modality of support. Most of the time, it's this blanket scattergun approach of let's just try everyone, and lots of people aren't interested, and it's a bit of a nightmare. This is actually
Yeah,
a
and
smart
it's
allocation of
something
resources.
like on the employer side, that's one of the most difficult things that we've had conversations with employer groups, and they're interested in what we offer because they know it can reduce their overall cost from a healthcare perspective. But you know, we have these conversations, and they work with other companies, but it's like they just throw everything on the wall and hope that something sticks. But this way, we get to just be a little smarter about it, and those who are ready to make a change, we get to help drive them, while also still trying to motivate and move those that are not in the appropriate stage into that stage.
And this is viewing the potential users of your product as prospects that you're cultivating and nurturing and then activating once they're ready. And this is the CRM mindset, which I think is lacking a lot from telehealth organizations, where they don't see their service users as people who they need to nurture and encourage over time. It's almost like you're ready
Yeah,
to buy, great, let's serve you, rather than how can we actively try and improve engagement, like we're selling something, because you're selling something to the service
right.
users. So it's cool to hear.
Yeah, absolutely. And I mean, it works very well. And we don't get bogged down with working with people that aren't ready for it. I mean, health is hard. And if you're trying to work with somebody who's not ready for it, I mean, you're just spinning the wheels. You're on that hamster wheel, just running and nothing's happening. So this even helps with, you know, prevent burnout even with our own staff, because they're actually, it's encouraging to them when they're building these relationships on these monthly touch points with these patients, and they're able to see the patients, generating outcomes, improving their health outcomes, and dropping their weight and improving their blood sugar and lowering their blood pressures. We've had some pretty phenomenal results with our outcomes. A1C as an example, or just blood sugar alone. We've seen significant reductions in blood sugars within 4 days of people using our program. And 100% of those who reduce their blood sugars sustain that. So it's pretty impactful by being able to leverage that readiness there to drive outcomes.
And so you're just to resume the patient journey, they go, so they get discharged from hospital and then they fill out a questionnaire, or they get discharged from a appointment, or they've had some interaction with their doctor. They send something to fill out a questionnaire, they fill it out, and then suddenly I'm identified as being someone who's really ready to change. What then happens?
So we put a lot of thought into how we get a patient actually enrolled into the program. So we have different channels, essentially, that can enroll a patient. Initially, the patient has that visit, or they have a visit, that a pre-visit assessment goes out, they complete it, they get an email that notifies them of, the outcomes of their assessment. They then have the opportunity through that, if they are identified as eligible, to create their account right there. We have a redeem code they have to put in that ties them to their specific clinic. And then another route is they come into the office. Now, we have put together a specific summary report of those assessments that we automatically send directly into the EHR. So the provider actually has that sitting in front of them before that patient ever comes through the door. And they have the opportunity to look at that, review it, see that they're eligible for a program, and offer that up during that visit with that patient. Say, hey, we see you completed your assessment. You're eligible for this program. Are you interested in joining it? And they're able to kind of sell it right there. And we see a lot of success when the provider is having that conversation, because patients tend to listen to their providers. They're coming to them for a reason. There's some level of trust felt there. That's another channel that we can get them engaged. But we also have post-visit. If they're identified, we have a team of individuals that will do a proactive outreach to that patient, a phone call just saying, hey, We know you had your appointment, the doctor talked to you about this, you completed your assessment. Are you interested now? You had time to think about it, or would you like more information? And we're able to, give them more information if needed, or go ahead and enroll the patient. And then they come back in within or after 6 months, they're going to be re-teed up to get that assessment again. So now we're giving, on an ongoing recurring basis, the opportunity to keep that front and center in the relationship to have with their PCP.
How does the clinic benefit? So obviously there's a massive benefit to the patient because they are having improved health outcomes. It's benefit for the payer, which is I guess the insurance company who you're providing the codes to, because they're reducing the total number of admissions. How do you, when you're chatting to clinics, are you saying we'll just improve the health of your patients? What's the actual, how do they benefit from it?
So those RPM codes, again, like I said, there's 12 total CPT codes that we leverage in the program, and we build those through that 30-day cycle. When we meet the criteria to be able to bill for those, that creates a significant revenue opportunity for the clinics just through the RPM services, and then those other, CPT codes that we identified. And we have different channels for a patient to be enrolled to. So we have like what we call our healthy living. That's the patient with metabolic syndrome or morbid obesity, or any other qualifying condition that's, preferably they haven't quite gotten to the chronic disease yet, because that's what we're trying to prevent. Or we have patients, that are, pre-diabetic or pre-hypertensive is the best one that I can call out. Is so somebody who has not got a diagnosis of hypertension, but they've had elevated readings. And so, they come in, it's an elevated reading, they're talking to the doctor and they're saying, well, it's white coat syndrome. Well, now we have a program that we can enroll them that's called our self-measured blood pressure program that models the American Heart Association's SMBP program, but we've digitized it basically. And now we're able to enroll them in that program, track them, and confirm that diagnosis. And if the diagnosis gets confirmed, then they transition into our hypertension controlled RPM program, where we can help support them on a monthly basis to reduce and eliminate the risk of hypertension, and hopefully get them through lifestyle changes to get their blood pressure reduced. And depending on, the medical necessity, they feel the patient still needs the program, then you can continue to keep them enrolled in that program to maintain the reduction of that risk. But some patients that feel confident, they've reduced that risk, their blood pressure is reduced, and they no longer need it, then we unenroll them from the program.
I've heard so much about preventative, but this is actually the first time I've seen it being
But
used.
you've heard a lot probably of what the payers call preventative, which is not prevention, it's early detection. And it's frustrating from an outsider kind of looking in is, a colonoscopy is not a preventive measure, it's an early detection measure. And that gets classified as a preventative, care. It's not, it's just early detection. And so we are really trying to prevent the development of those chronic conditions. And if you have those chronic conditions, we're trying to manage them using lifestyle choices. It's very small things that we're asking these patients to do on a daily basis, such as
Stop.
just
Yeah.
park a little further when you go to the grocery store. Don't park right in the front spot. Go 2 spots down. You're gaining another 20 steps just by doing this. Put your fruit out on the counter so that you see it and you're hopefully more motivated to eat an additional fruit for the day. We create micro goals with them so that they have something to shoot for, but it's the small changes that over time build a much massive outcome for them. We've got a patient that's a wonderful example. He was a construction worker, or I'm sorry, a forklift driver. I want to say he was 400 plus pounds, so quite heavy. He got enrolled into our program, and he signed up for his plan to be walk more, or move more. So what he started doing is just in between his time actually on the forklift, he just started working around the job site, just walking around it. Just taking that time just to do a little walk around. And he's lost over 175 pounds now. His next plan, I think, was like drink more water. So he started, making sure he always had a water bottle with him. And we give them daily tips to help them kind of just be mindful of, what their plan is and what they're trying to achieve. But in each one of those plans are little tricks, kind of like life hacks, if you will. And we're in the process of generating that using AI. So it's going to get smarter the longer they're in the program and the more we learn about them. So A good example is, a grandfather who is very passionate about his grandkids and loves spending time with them. The system learns that he enjoys spending time with them. Well, now it's going to spit out, recommendations for move more, like maybe take them to the park today, or maybe go on a walk, down the street with them. And it uses the grandkids as that motivator to getting moving.
This is so far ahead of so much I've seen in terms of actual working with clinics to implement. I never really said this exact thing 4 minutes ago, but this seems like such a logical next step that you are already stepping, that anyone who has a high likelihood of developing a chronic condition should be, if they are willing to, using. How is this being perceived? And I'm not normally, I mean, you can watch the other podcasts. I'm actually always hyped on podcasts because I love podcasts, so I can't lie. But when it's something that is a logical next step that you have said that lots of people aren't aware of, how do you then decide which markets to go after? Are you going after mental health? Are you going after obesity as your main one? How do you cut the pie and actually advance when you have so much potential within this space?
Absolutely. So there's lots of different ways that you can look at that. So I guess I'll answer from a couple different perspectives. I think part of what you've asked is how do we decide which market space to get into? So to your point, we're working with primary care providers. I've mentioned that, we've got employers that are interested, and we're in the process of doing some pilots, some with employer program type stuff. What starts to look a little different is in the employer space, we don't necessarily have the PCP as part of the equation. One of our key things in this. So to your next point is how do we get others introduced into the channel to get them to use this product is maybe the idea is we offer this up and partner with an employer to get the next sales cycle that we're working with. So now we're going to get a bunch of individuals and now we can start asking them, who is your provider? Now we get to go to the provider with information in hand. We've already got 200 of your patients enrolled. This is the revenue opportunity you're missing out on. This is the outcomes your patients are already seeing. There's no downside to this. Why not join up? And while we're at it, you're going to stop and slow the bleed of patients that are looking for these GLP-1s, or you can even use this as a supporting program for your GLP-1s. And you're not going to lose them to new. You're not going to lose your patients to these other services that are providing this fractured care for your patients that you have no idea what they're doing with them. So now you have a much more robust and you have a better continuity of care for your patients.
So it's like a evidence-based bottom-up approach where you're saying, hey, look at all of the traction we've already had so far with a fraction or if almost zero of your actual support.
Yeah.
And now imagine how we could look both for these patients and the rest of your cohort if we partnered up and made this something which was a default.
Right. And I think one of the key things to our outcomes is the fact that the primary care provider is part of the equation. And so it gets challenging on how we decide, which market or which phase do we go into next. I mean, there's plays within like the concierge care. Maybe a concierge doctor has a higher tier where this program is part of it, and if a patient qualifies, so now they're willing to pay a little extra to be in that tier and receive our program as part of the concierge care that they pay on a monthly basis. So in that model, you're now eliminating the need for CPT codes, and it's just a part of your regular care.
What
There's
is
different ways on how we think and how we're thinking and how we're approaching, I guess, the next steps. I can say also, I guess to your point of the initial question is we're also looking to become that platform that is the feeder using our AI model to identify the needs of the patients. So we build the base through our program, and that patient's now in a stage of change. They're in a behavioral mindset that's working. They've seen outcomes, so they're motivated. Now, what is the next step? Are they ready for something a little deeper, a little more robust than what we are offering? Now we can feed them to, an actual weight managed, like physical weights or aerobics class or a nutritionist that can give them that deeper insight into how to better prepare their meals for greater outcome.
And then that's a really cool business model in itself because then you potentially become, either a marketplace, which is saying we have these 6 nutritionalists and you offer these as to patients, or you say to the patient, hey, we have this preferred recommendation for nutritionists, and then you have a really good partnership. Let me know if I'm getting this wrong, just trying to summarize. And then you have a good relationship with the
Yeah.
partner, who is then you're sending them hot leads, not to objectify patients, but you're sending them people who are ready for their service. And then it's just a strong collaboration between you handing someone over who can get more assistance.
So while keeping the PCP the center point of that relationship too. So it's wonderful that for the clinics, there was a survey last year. I can't remember who put it out, but one of the number one things that providers wanted was support with nutrition. And the payers right now, some of them pay decent for the services. You run into the situation of ROI, is it worth it or not? And in some cases, it's not, depending on where you're at in the market. That's an example of, how we hope to create a smarter system that is able to leverage those things, that makes that ROI more meaningful and allows those providers access to those resources that they really do want, but it's fractured, it's difficult to refer, and we can centralize it and ensure that the information is flowing appropriately.
Amazing. Well, David, I'm really sad because we are up of time and wow.
We'll have to do it again. We'll get some more time.
Yeah, I really, really appreciate it. As a last thing is, as someone who's experienced in the industry, encouraging advice would you have? Because this is one of the key things we try and share as well for new entrepreneurs and new innovators in the space. What encouraging advice would you give to people who are thinking about bringing innovation and a new idea into this telehealth, telecare space?
Absolutely. I guess one of the biggest things I can say is don't be scared to try it and really think outside the box. And if you have questions about it, work with your payers. There you have individuals that are assigned to your clinics that are assigned to work with you and answer your questions. Find out who those people are if you're unsure of how you want to try something or do something, and get the answers, figure it out, and think outside the box. We have the box that healthcare and our society has given us, but you can bend the rules. You can manipulate within that box and still be successful and still create something. You just have to be creative about it.
That's very motivating. David, it's been a huge pleasure. Thank you so much for your time, your wisdom, and your encouragement to think outside of the box.
I appreciate it, Monty.
Look after
It's been a good
yourself.
time.
Peace.